We're live.
Great. So this is Senate Finance. It is February 6th. Senator Cummings will be joining us shortly. She's at the joint I forget the title. She's at a committee meeting and should be here shortly. And on the agenda for today, we have Vermont Education Health Initiative. So we're going to start by hearing from Bobby Jo Souds, and I welcome her to the chair. If you'd like to share your screen at all.
I think we have handouts instead. It was very wordy, so probably doesn't look great on the screen.
Oh, Mark, you want to join her?
Thank you.
Yeah.
The chair is great.
We also provided a copy of our FY27 rate filing document. You may find that of interest as well. We may refer to it, and you can also look at it in the
I don't believe this is pertaining to any specific bill that's before us in this finance.
Our understanding is you wanted an overview of what the cost drivers are for VHI and what VHI is and what we do. That's sufficient. We're certainly prepared to speak. We're also happy to take questions either during our presentation or at the end to get your questions. Let's get discussion.
All right. Well, thank you for having us. I'm Bobby Jo Souds, and I work for the Vermont School Board Insurance Trust. I'm the director of VHI programs. And it's my colleague, Mark Hage, who works for Vermont National Education Association, Vermont NEA. So we work together on a daily basis on all things VHI.
Sorry.
So we just want to stress at the outset that VHI is not alone in facing these rising costs and prices, especially for hospital and pharmaceutical services. It's a critical problem across the state, both regionally and nationally. Vermonters are spending almost 20% of their income on healthcare, compared with the national average of just under 8%. So all self-insured risk pools and insurance carriers are confronting the same problems and cost drivers, and this includes an increase in utilization of care. So the costs are going up and the utilization and how much is being used is going up as well, which is a combination for increases. So VHI is a Vermont Education Health Initiative. We were established in the 1990s. We're nonprofit, self-insured, and intermunicipal insurance association. We are regulated by the Vermont Department of Financial Regulation, VFR, and we contract with Blue Cross of Vermont for actuarial and administrative services for things like claims processing and customer support. So we are the health insurance pool, and they're like our TPA, really. They process claims for us and such, and many other services. So we provide health insurance benefits to every public school in Vermont, as well as some private education institutions, and to a snippet of the Medicare population through visitors. So we have the Vermont State Teachers Retirement System. We have their pre-Medicare retirees. We have about 800 of those. I think those are on the next page. And then we also have about 1,200 that are Medicare, that are not yet eligible for the Medicare Advantage plan that most of the retirees are on. So they still have a kind of a Medicare supplement plan, a more traditional plan through VHI.
Can I ask about that? So I know that there were a lot of Medicare Advantage plans that kind of exited the state, but yours is still intact?
Well, so Visitors contracts themselves. We do some administrative work for them, and they have our wellness program. They had their plan through Vermont Blue Advantage, which was affiliated with Blue Cross of Vermont. Because of an increase, they switched to Health Springs, which was another Medicare Advantage plan. So they have about 7,000 people on that plan through Health Springs as of January 1st. And we have about 1,200 that are on Med-Sup plan, and then another 800 that are pre-Medicare. So they retired before Medicare age.
Okay.
These retirees were not impacted by Vermont Blue Advantage and MVP leaving the Medicare Advantage market.
Okay. Yeah, that was basically my question.
Yeah.
Like it's still intact.
Yeah, the VHI portion is zero.
Okay.
May I just ask, you moved to another plan to replace the Medicare Advantage plan from Blue Cross Blue Shield. Was the plan that you moved to cheaper or more expensive?
It was Visitors that made the contractual decision to move.
Yeah.
So they weren't our plans, but as Bobby just said, we did some administrative and oversight work.
But it was who you chose to.
No, Visitors chose to.
Visitors chose.
Retirees.
Okay, you did not have the
Correct.
ability to make.
But to your point, yes, the overriding decision to move was because of cost. I think the cost increase came in at nearly 50%, and that was just unacceptable.
So you were able to, so they were able, when they moved it, to find a plan that was less expensive.
They very quickly, definitely found another carrier who could provide comprehensive coverage at a lower rate increase.
At essentially the same coverage.
Exactly.
Yes,
Same coverage,
exactly.
yes.
How much of a savings did you achieve as a result of that? Do you know?
We would have to check with visitors, we were outside of that.
Yes, I would be very interested to know in terms of just how much of a cost reduction.
My
we made.
recollection, when they moved to Vermont Blue Advantage,
I think it was 19.
I want to say 19 million worth of savings. And that would have been in 2022 when that plan became active.
Yeah.
So it's a significant savings when the plan was launched.
I think the first 2 years they had, increases in the 8% range, if I remember correctly, less than 10. And then the third year came in just way too high, so they had to find something else, but they were able to find another carrier,
Okay, good.
and offer the same plans.
Thank you.
If I can ask, you also mentioned how both cost and utilization's increasing. In what you recall, what you've seen of the numbers, is there service areas, types of care that are outpacing the increase in utilization relative to the other categories?
I think I think we're gonna talk to some of that. Cost wise, we'll talk to some of that. I don't know if we can talk to utilization specifically. But
I think utilization is fair to say is up across the board, but we are seeing some fairly dramatic increases in costs for musculoskeletal conditions, cancer, oncology medications, diabetes, asthma, COPD. And those categories are generally high cost categories, so there's no surprise there. But there is, I think, been an intensification of utilization in those areas and also increasing prices.
The carrier that you are now using, I assume is a multi-state carrier?
It's Blue Cross of Vermont, they're our TPA, so we're self-insured. We
Okay,
carry all our risk
okay,
and we contract with Blue Cross to pay claims, as Bobby Joe said.
all right.
They're help with our wellness program. They do a variety of services.
So do you have any sense of whether or not the costs that you are incurring, particularly for these particular conditions, are out of line with what people are being charged who use the kinds of services you do elsewhere outside of Vermont?
I don't have that kind of national analysis of
Okay.
my fingers. What I can say, I think confidently, Bobby Joe's opening remarks alluded to this.
Mhm.
We're seeing a dramatic increase in cost nationally,
Mhm.
statewide, regionally. We're also seeing an increase in utilization across the country as well. So whether our costs are going to be more costly, less costly, that kind of analysis, we don't have to answer.
But it is fair to say that there are certain services that, depending on where you get them, even in Vermont, vary widely.
Yes.
So, and we put out a notice about that a few weeks ago with the help of some information from Blue Cross, where labs, range from $54 to $650, depending on where you went. So, there definitely is, that's a piece of it for sure.
I mean, before the legislature passed Act 55 last year, which capped the cost of hospital administered medications at 120% of average sales price that CMS says. Vermont had the most expensive hospital administered medications, more than 500% down of the CMS rate. So nationally, in that regard, unfortunately, we were a leader.
Yeah.
Not a distinction we wanted.
All right, so I'm happy to take any more questions, but just to move forward. So we have about 33,000 active school employees and their dependents that we cover. So we're covering the bulk of the school employees, 33,000. We have, again, just about 800 that are non-Medicare retirees and 1,200 that are Medicare retirees on that plan. So this is, again, outside of the visitors plans that they have that are Medicare Advantage. We have a board of directors that has 6 members. 3 are appointed by the Vermont NEA and 3 are appointed by the SBA, or the School Board Association. The management team responsible for day-to-day operations. There's 4 individuals, myself, Mark from the NEA, and then 2 of my colleagues at Bisbit, which are John Steiner, he's the CEO, and Chris Roberts, who is our finance director. Most interactions, Mark and I are lucky to handle most of them.
We're looking at Vita.
I work really directly with the central office staff, business managers, human resources, and Mark works with local union leaders as well as school employees who escalate calls to him. So this has, again, been dating back to the 1990s that these groups have been in partnership. We also offer, outside of our health plan, we have dental, and we also have long-term disability and life plans with Northeast Delta Dental and National Insurance Services. And a big part of our program is our PATH Wellness Program, which is administered by 4 of my teammates at Isbent, which is it's a very well established plan and very popular with our employees.
Can I ask a question about that? Because I'm a former educator and I always like the PATH program, but do you all collect any evidence as to how it's, if it's working and?
Yeah, we work closely with Blue Cross on that, and they do a lot of data analysis. They're, de-identify everything and say, all right, if I take these, 1,000 people that did the survey and take the same, people just like them, the same age, the same gender, the same location, how do their claims compare? And the PATH program has better experience. We do have some information.
Yes, some data later.
Yeah.
presentation.
So Lehigh offers 4 health insurance plans to our school districts, public and private. They have access to medical and prescription plans and all the same networks across the board. And there's a link in the electronic version to our plans if you need to see them. And then we have 3 benefit plans that we offer to our pre-Medicare retirees at Visitors. Let's see. So we set the rates for our premiums separately. So we've got our Visitors group, and then we've got our Actives group, and our Actives group renews on fiscal year in July, and we do that for budgeting purposes. And our retirees are set on a calendar year. So they have different plans, different experience, and their rate filings are done differently and separately, independent of the other. So our premium rates for both subscriber populations are approved by DFR. Those are the actuaries at Blue Cross calculate them. They're sent to DFR in the filing, and then DFR works with another actuary that validates the numbers, and they usually get our rates approved for us in the beginning of January. So to kind of give you an idea of how the rate cycle works, the rates for FY25, which is July 24 through June of 25, were set in the fall of 24, utilizing claims from June of 23 to 24. So by the time you look at the claims from June or July of 23, these are the rates that are set through June of 26. So there's really a long span of time. And there's a lot of catch up that we end up having to play as certain things come into play.
So can I ask you about that? So Mark brought up the work we did last year with the hospital prescription prices.
Yeah.
When will you see that?
So we filed that based on the work that was done, Blue Cross did the analysis, and we filed that as part of our FY27 rates. And it actually on this next page, it kind of shows you the difference between the two. And so I'll talk about that in 1 second. So just to kind of follow this, the premiums and the out-of-pocket expenses are set at the statewide bargaining level. So years ago, each local school had their own bargaining, and then a number of years ago, the statewide bargaining went into play, and they decide each year or for every couple of years who pays what for premiums, and if there's any out-of-pocket expenses that are held by the district or the employees. So moving into rates. So if you look at our rates, our FY26 rates increased just under 12%. And
So just so I'm clear, the work from last year will go into the rates for next.
so for July of this year.
Oh, so that your fiscal year is June to July, like this
Yeah.
date is.
Yeah.
Okay.
Also, we will see some savings as well.
That's true.
In the second half of this fiscal year, because some hospitals implemented the Changes Act 55 set in motion earlier than required. So we'll see some savings this year, and we will see, as you'll see, very significant savings.
Okay.
But it is baked into, so what not only FY27, but some of the FY26 has been baked into the FY27 as well, because really it was like 18 months worth of savings. Because the rates had already been set a long time ago for this period, so.
Yeah, okay.
But yeah, it does definitely get confusing on which I sometimes forget what year we're in.
Yeah.
So when you look at our FY27 rates, to your point, our increase was, I think it averaged at 7.3%, which was significantly better than the last few years. And this really had to do with, some of the changes that were put into effect from the legislature, Vermont Care Board, as well as to stop covering GLP-1s for January 1st for weight loss. And that was a difficult decision for the board to make, but if we had included it, it would have increased our rates overall by 4 to 5%. So we've It was like $16 million. It was a lot.
We were
So-
just talking about this yesterday. We were thinking about the presentation today. I was looking at some data and from 2023 to 2024, our independent pharmacy analyst looks at a lot of numbers for us. Told us that the anti-obesity pharmaceuticals went up a gross cost of 178%. You combine that with a sharp increase in volume and you get an additional 4 or 5 points on premium just from that.
Amazing.
So while it was a difficult decision, we felt like, especially facing year after year of double-digit increases, we had to do something to keep costs down.
Yeah.
So that was one of the decisions that we made. And to be honest, when you're looking down through the allocation of premium dollars, typically that 84.4% of premium dollars that it shows there, it's actually closer to 89 most years. That usually of the 100% of the premium that we get, 89 to 90% of it goes right back out the door in premium and claims paid. This year, it's a little lower because we had to rebuild our net position or our reserves because things like the GLP-1s had us losing, we lost $20 million out of our reserves in FY24 and FY25 unexpectedly because of the sharp increase in those prescriptions, not only in the cost, but in the utilization as well. And it wasn't baked into these rates that we set, 3 years ago. So we had to rebuild our reserves. So we're hoping that rebuilding our reserves will get our net position back to a favorable level. And DFR has agreed with that and approved our rates for FY27. So about 4% covers administrative costs for Blue Cross and internally at Beehive. Blue Cross is really only, it's about their administrative charge is about 3.2% of our rates. Which when you look at fully insured plans would be significantly more. 1.8% covers state and federal assessments, and 0.6 is our wellness program. So that's the rate allocation this year, but it does change year by year as we have to adjust things based on increases and such.
Also, to expand a little bit on Bobby Joe's comments about the FY27 rate filing, I believe the decision not to cover them for weight loss alone, this will cover them for diabetes, for cardiovascular conditions. I think that was like a $16 million savings for us, roughly. And we were able to lower projected spending in FY27 by approximately $40 million. 16 million of that's attributable to the GLP-1 decision. However, 14 million is attributable to Act 55. And roughly $10 million is attributable to Greenmount Airport's directive to the hospitals that they will file budgets in the FY26 year at or below the board's recommended guidance, which was 3%. All the hospitals came in at or below that level, and UVMMC's budget, of course, was cut by about 88 million. That decision was a $10 million savings for us. With the Act 55 savings, we're in the neighborhood of $25 million just by addressing prices, right, and price inflation. So those two decisions were very impactful. And again, for Act 55, for us, Act 55 was just like a mono. So thank you for that.
Something right today. All right.
You don't need them.
No.
So I'll drill down a little bit into these big cost drivers, and as Bobby Joe's already stated, and this is a consistent theme. Our two biggest cost drivers are hospital prices and pharmaceutical prices. Hospital claims account for roughly 55% of our total spend, inpatient and outpatient. 44% of those claims come through a hospital in the University of Vermont Health Network, and the lion's share of those claims are with the University of Vermont Medical Center. We have a high concentration of employees and family members who, of course, live in Chittenden County. 20% of our spend in total is on pharmaceuticals. So 75% of our spend is attributable to hospital care and pharmaceutical care.
Just a question about that 20% on pharmaceuticals. Does that include inpatient stays or like cancer treatments? Or
Inpatient treatments at hospitals are under our medical.
okay, so you wouldn't see that
Correct.
under prescription.
That'd be mostly retail and mail order.
Wow.
And that's one of the fastest growing sectors of the healthcare industry as well as the pharmaceutical.
That's kind of like mirrors what we hear.
Yes.
Hospitals and pharmaceuticals are the big.
We have a quarterly meeting with our independent pharmacy analyst, friendly analytics, and the numbers are staggering. And what you're going to see in the pages that follow, most spending in healthcare, whether we're talking about medical or RX spending, is incurred by a relatively small number of people. Most people do not get a lot of that. But those who do, especially with chronic conditions or severe conditions, generate enormous costs. And that's true, again, in both the medical and the RX field. So one of the things we do with Blue Cross, this was an initiative by VHI, is we ask for a cost stratification analysis of each. We want to know what we're spending on our top 1% patients, what we're incurring in cost for the top 5%, and what we're incurring in cost for the bottom 50%. When we say bottom here, we mean the people who incur the least amount of cost. And this cost stratification analysis was actually inspired by something that the federal government does. The federal government's been doing this for about 50 years. And what's really illuminating is you tend to see the same percentages year in and year out, whether you're talking at the federal level or the state level, or even for a pool like VHI. So for example, roughly 34,000 people in 2024 in our pool of active employees, 344 of them made up our top 1% of claimants. That was 25% of our total spend. 344 people, 25% of total spend, and an average cost, as you see here, of $286,152. The top 5% of our claimants, that's 1,720 patients, accounted for 52% of our total spending at an average cost of more than $116,000 per member per year. When you look at the bottom 50%, now we're talking more than 17,200 patients, they account for just 5% of our total cost at an average of roughly $1,100 per member per year. Our high cost members, and there's some more data here in the table you can see, these are folks who exceeded $100,000 in cost. They numbered just 580 people out of that very large pool, but they incurred costs of almost $122 million. And you can see in the table below the sort of progression from 2021 to 2024 of high cost patients, those exceeding $100,000 cost, and the impact on our total spend and the percentage of spending that they represent for the pool as a whole. So in 2034, those 580 high cost members accounted for a third of our total spend. Now, as we mentioned, pharmacy continues to be an area where we are devoting a lot of time with respect to cost containment and doing so in a manner that does not compromise the health of our members. And Remedy Analytics, a longtime partner, we've been with them now for 10 years. They've been very helpful in illuminating for us where we are spending money and in what categories here. And so once again, small number of RX patients, like the small number of medical patients, drive most of our costs. Our total RX spend in 2024 was a little over $90 million. That was an 18.4% increase over the 2023 number of 76. We had 404 patients out of our pool who took medications that cost $50,000 or more. So again, relatively small number of people. They represented nearly 49% of our total RX spend. We had nearly 4,900 VI subscribers, 14% of our pool of funds that did not even use their own. You turn the page, number 6. We thought it'd be helpful for you to see the impact of specialty medications versus generic or low cost non-brand medications for starting spending. There's no common definition of specialty medications, except that they're really expensive. And they're often the most expensive medications in the market. They tend to require special handling and storage, often prior approval criteria is stricter. But without question, the most expensive medications we see year in and year out. Now, in this category, there's 995 people in 2024 who needed specialty medication. That was just 3.3% of the patients in BI who actually filled the prescription. Again, very low number. But their average gross cost was $50,000 in 50,030. Those 995 patients drove nearly $50 million in gross spend, or 55.1% of our total spend. Bobby Joe and I have been watching this gross percentage grow year in and year out. I think when we first started working with Remedy, if I recall correctly, specialty meds at that time represented roughly 35% of our total spend. In 2024, they were 55.1%. And we don't see an end to that trajectory at this point in time, barring some very significant price regulation. Now, generic medications, roughly in the early 2000s, we discovered at VHI that our generic fill rate was much lower than we wanted it to be. And generic medications have the same ingredients, they're medically efficacious and profoundly less expensive. Their costs can be anywhere from 70 to 80% less expensive than the brand drug. So we undertook a major education effort in the early 2000s to encourage our members to learn about generic medications, to talk to their physicians about it, and whenever possible to use generics. And we were successful in a relatively short space of time. So roughly 86% of our members today take a generic medication when they need to, or when a prescription is prescribed for them. So in 2024, more than 23,600 of our members took a medication that cost between $1 and less than $1,000. But notice the average cost here compared to the specialty vendor. The average cost for that population was $197. And they represented, again, 86% of prescribed medications in 2024. So our members are doing what we asked them to do by and large. They are taking generic medications, the lowest cost on the market, or they're asking for a low-cost, non-brand medication. And even there, we're still seeing just tremendous increase in pharmacy.
Can I ask a question? So I can't remember, I mean, we've had this conversation, I've participated in this conversation about generics down the hall a bunch of times, but I can't remember. I mean, can you require that people get generics over if there is a generic alternative?
Well, I know there's expenses written in.
Yes, I think what often happens, we can look into this more, but my understanding is that if a person with a prescription goes to a pharmacy, I believe the pharmacist is required to provide the lowest cost option, unless there is some medical reason why that is not good for the patient.
Okay.
We have never actually told people you have to get this generic, but I believe the way the system is structured, that's effectively how it happens.
Okay.
And again, the education effort was really successful.
Well, I mean, if that's true, if it's true that there's a law that says the pharmacist has to provide the lowest cost option, then you educating your members about generics isn't necessarily a cause and effect, because if the pharmacist is already doing that anyway by law.
The education we started began well before what I think when this law.
Okay.
Okay. The other thing is when Humira is a medication taken for rheumatoid arthritis and really chronic pain, very successful medication. No exaggeration, nearly 2 decades, it was the most expensive medication that we paid for.
Yeah.
It was protected by like 140 patents. So for 2 decades, manufacture that drug made a lot of money. It made a lot of money from us and from the people we serve. Humira is now a biosimilar, which is a fancy way of saying generic. We do not allow coverage for Humira any longer. You have to take the less expensive, just as effective generic or biosimilar.
Mhm.
So we have taken those efforts in.
Yeah, I just wonder across the board how do you get that out or not.
Yeah, unfortunately, there's just a lot of medications that don't have the
Yeah.
generic equivalent. you know.
Yeah.
So like some of these really high cost drugs, there's nothing to refer them to. You know,
Yeah.
So.
Yeah,
There's
there's a certain number of years that go by before, yeah.
I think the typical patent is 20 years, if I remember correctly. So.
Make a lot of money first.
Yeah.
Yes, they do. And we just thought you might be interested to see just 2 categories of medications where we incur a lot of costs. And again, anti-inflammatory conditions are a major cost factor. And not a lot of patients in our pool need these medications, just 476 in 2024. But as you can see, the average gross cost is in the neighborhood of $64,000. And the medication for diabetes, and we cover insulin at no cost. That has always been true. We have roughly 1,800 people who need diabetic medication, and the average gross cost for that in that category is a little over $12,000 per kid.
This is active teachers or is
Either
it
school employees.
school employees, but not the retired? Just as retired teachers?
It would only be just the 800 that are included, that haven't hit Medicare age yet. So those that retired before they're 65, it might include those 800, but for the most part, it's just.
The Medicare Advantage folks, so this just serves to be on a different set of numbers.
Yeah, no, I'm just because we set up retired teachers' healthcare, we set up basically, when we were working on pensions, we set up a fund. It was just,
Pay as you go.
yeah, it was just pay as you go for a while. But if this does include them, then
If it includes them again, as Bobby just said, it's a pretty small population.
your numbers sound percentage-wise pretty close to what I've seen for the general population.
That is correct.
Where the thought is the teachers are generally younger and healthier, and so your cost should be less. But if you're picking up that older group, then that
That would certainly contribute to it.
okay.
And of course, it's all public school employees, so not just the teachers, but educators and
Right.
School administrators,
Yeah.
licensed and non-licensed school,
And their family.
and the dependents.
Yeah.
correct.
Yeah.
And can I just add one thing, Mark? Just when we're throwing a lot of numbers around and talking about, 50% of this cost. But just to give you an overall, our expected revenue in FY27 is about 400 million. So we're talking about really big numbers. Each week we receive a claim file and a bill from Blue Cross that says, these are all the claims we paid out this week. And we pay out about, it's between, depending on the weeks, between $6 and $10 million a week in claims. So, big dollars coming in and out for sure.
And once more, thank you for Act 55. As you can see at the end of page 5, at page 6, it's a almost $15 million savings for us in FY27. And we haven't seen that kind of number in RX for a long time. So price regulation works. And in this particular case, it was immediately effective. That law had been in effect for 2 years running now, and saves, I think, would have been in the neighborhood of like $26 million for us. And you should know as well, this is drawing attention outside our borders. We had people contacting me about it from other states saying, wow, what's going on with the prescription medication regulations? So the work that you did is drawing attention beyond the So looking forward, as I said, Dr. Joe and I spent a lot of days and lose a lot of sleep thinking about how to control pharmacy costs. And so one of the things we're doing is considering contracting with a new pharmacy benefit manager or staying with our current pharmacy benefit manager, which is under contract with Blue Cross, but on more favorable terms. So we put out an RFP for a pharmacy benefit manager in 2025 after researching for a couple of years new competitors in the PBM market. The PBM market is highly consolidated. The top 3 PBMs control 80% of the market. One of them is Optum, which is under contract with Blue Cross. And Bobby Joe and I thought, why don't we go out and see what the competition can offer? They're called generally next gen PBMs, right away Capital RX. And they operate very differently than the big 3. They have been delivering some very significant cost savings in both the public sector and the private sector. So we put out the RFP, we interviewed 4 candidates, I think it was. And what we can say without, no decision has yet been reached, but whatever decision we make as a result of this process, whether we stay with the current PBM or we move to a new PBM, we're looking at several $1 million of savings each year for the next 3 years.
What is several?
I said high single digit with that. Until we sort of finish the process, we'd like to keep the actual.
That's fair, but several has a lot of range.
Let's say high single digit.
Okay.
Very good, good. Okay, so we are also always looking for possibility for new partnerships and vendors to deal with high cost conditions. As you can see from the earlier numbers we shared, small numbers of people with severe or multiple chronic conditions can generate an awful lot of cost. Is there a better way to serve those populations, particularly in the arena of chronic care management? Any pool you look at, and you look at federal data as well, overwhelmingly most costs are generated by chronic care management. Anywhere in the neighborhood of 70 to 80% from one year to the next. So can we help those folks get more timely, high quality and affordable care? So for example, and I think our GLP-1 conversation over the last couple of years helped propel this thinking. Is there a vendor out there who can help us independently work with folks with type 2 diabetes? And recently we've been approached by a vendor whose presentation was very impressive and the numbers were impressive. Bobby Joe and I hear a lot from vendors all the time, promising us a lot. So we move very slowly and cautiously and carefully in this arena. But this is a vendor that looks promising. We're going to continue to do more research. These kinds of approaches are in our business called point solutions. You as a self-insured pool go out, you contract with an independent vendor, and you provide services in a sort of non-traditional way and in a more personalized way to address chronic conditions and other high cost conditions. We also want you to know that we were very supportive of another act that this was in 2024. You gave prescription drug affordability authority to the Green Mountain Care Board. You created a division within the Green Mountain Care Board to begin building a framework and a methodology for lowering the cost of these specialty meds and other high cost prescriptions. So again, we understood immediately when we saw that legislation, it was important, it was going to be impactful for us and for all Vermonters, and we endorsed it. And we're looking forward to seeing how that division carries out its work in the years to come. There are prescription drug affordability boards across the United States. And Maryland was the first to do it in 2019. Vermont and EA picked up that ball and ran immediately with it. And since then, other states like Colorado, Maine, et cetera, have also instituted a prescription drug affordability board. So what we're seeing nationally is again the recognition that if we want to bring down cost, we have to regulate prices. With respect to hospital costs, again, this is 55% of our spending. So we are now at the early stages of a new benefit design process. Bobby Joe spoke to the 4 plans that we currently offer. We've been tracking what's happening in the national market with benefit design and new ways to get at prices and costs, again, without compromising access to care. And so we want to look at a new benefit design process that will help us to incentivize people to get the best care they can, the best access metrics outside of hospitals. And this will mean, and again, this is also part of what Act 68 did last year. Act 68 also speaks to primary care, revitalizing, restructuring primary care, getting people in the Act 167 report, get as much care out of hospitals as you can and get it back into the community setting, doctor's offices, primary care and mental health, that sort of thing. So we want to look at benefit design options that will do that. And we're going to be contracting soon with a benefit design consultant who can help us think in new and innovative ways about how benefit design can help us to advance what it is you're trying to achieve with Act 68. The other thing that interests us, and again, this is in the early stages, there are pools and there are big employers who contract directly with hospitals. And they are using reference-based pricing as one of the ways of determining what a fair price is for hospital services. And there are states like Indiana, which passed a law last year that said if a self-insured pool like VI or an employer contracts directly with a hospital, you will charge them no more than 250% of what Medicare charges. Where statutes don't exist like that, as I said, employers or pools can go in and negotiate on their own. So as we watch reference-based pricing be implemented here in Vermont, consistent with Act 68, again, very, very promising. Cannot say that enough. We will be looking to what extent we can, we should be looking at doing this on our own, Or again, just piggybacking on what it is that Vermont Care Board will be doing.
Yeah, we have a question for you.
So benefit design process, I mean, how much within what has been negotiated can you shift around the benefit design?
We can design a plan, based on what we believe is in the best interest of school employees at VI. So the statewide bargaining plan doesn't dictate the services, that we offer.
Okay.
benefits, for example.
But does it dictate things like co-pays and things like
Correct,
that?
statewide bargaining does.
Okay, so that you guys can't, that has to be part of the bargaining
That's part of
process,
bargaining.
because I mean, that's one
So
way
we
to adjust the
create-
cost. of
Yeah,
the
we
plan.
create the plans, but then they
They bargain.
over them. So, you know,
Okay.
we can recreate whatever plan design we want and then they can. You know,
Yeah.
kind of separate, you know, decide who's paying what.
Okay, and I have another question that I have mixed feelings about, but so one of the things that one of my school administrators was talking to me about was some kind of analysis to see of if you have a two working household, like, you know, both adults in the household are working and they both get benefits through their employer, but one of them is a teacher or employed by a school, they're more likely to take the school plan than whatever the other plan is, because it's almost always a better plan. So I'm wondering how, I mean, it's awesome that those people have health insurance and good health insurance. But I'm wondering if you've done any analysis to see like how much you're picking up of costs, because you know what I mean? Like I said, I have mixed feelings about asking this, but I'm wondering if it is any bit of a cost driver.
I mean, sure, it costs more to cover, you know, an additional member. It is a higher premium, so they're paying a higher amount for it. We have not done an analysis to say if we stop covering spouses. I have heard of some small employers.
I'm not suggesting stopping
know.
covering spouses,
No.
believe me.
No, I know.
I'm a spouse who's covered by my
Yeah.
spouse, so I'm not suggesting that.
I'm not suggesting either.
But also just to sort of see, it is a little bit of a cost shift, and you know, I'll use my own community as an example. So we have Middlebury College that tends to have pretty good health insurance, but I think our school health plan is even better. So there are people who have a spouse employed by one or the other, and they're taking the school. So like almost you're kind of saving Middlebury College some money there. So I'm wondering like if you've done any of that analysis and if there's a way to tweak that. And I don't have ideas, I'm just curious.
And we don't have access to what spouses.
Yeah, I mean,
Insurance.
it's touchy because you don't have the data to do it and it's kind of private data, but also just wondering if there's.
There has not, we've not done the analysis on that. And honestly, I think it's really the first time it's come up. to be
Yeah.
honest.
I'm only asking because one
Yeah.
of my school administrators mentioned it to me
Yeah.
and I was like, I don't know, I had no idea.
Right.
You know?
And even where there is a cost shift, let's assume for the sake of argument, there is in some cases. Big picture, it doesn't change our dynamic.
It's probably small,
Yeah.
and I mean, your point about the premium is higher, but I mean, as you're thinking about the premiums too, which is also a negotiated benefit, but I'm assuming it's part of the negotiations, but just thinking about that dynamic and how it might be playing out, and it's probably very different across the state. My community's has a different situation than others, yeah.
Yeah, no, the reason I brought that up about the spouses, my husband works for an employer and his, they sent something out that said we're no longer covering spouses as of January 1st.
Yeah,
It just kind of.
Don't do that, that's not what.
No, I'm not either. I'm not even. So it's funny that you brought it up though. They've just kind of recently come up, but, yeah, we'll take it back and kind of
Ponder.
Yeah, we will
Okay,
ponder.
thank you.
Who's looking at us?
So 5B.
Yes.
Oh, go ahead. I'm sorry.
Got one quick one, sorry. So along those lines, your FY 27 rates, platinum single, $1,400. What? That's the cost of the plan to the school, right? A month?
No, that's the total cost.
Right.
So that's the total premium.
So
and
what-
then the school
what-
pays 8%.
Okay,
Right.
so 20%, okay. Just wanted to make sure.
And actually, just one more thought on your question before, which is some employers have a cash in lieu of benefits option. So
Mhm.
it's cheaper for them to say, I will pay you $5,000.
Yeah.
You know, so that plays a role as well.
Yeah.
Okay, good. So, thank you.
Future comings. as you know, we're under a tremendous amount of pressure to bring down healthcare costs and to generally bring down education costs, in the form of, property taxes and so on. Are you gonna speak a little bit to how you are governed and who is responsible for making these cost decisions?
Yeah,
Or could you,
so we talked about who, kind of runs VHI, if you will. So we have a board of directors, 3 appointees from Vermont NEA and 3 from the Vermont School Board Association. And they really make the decisions on, the management team will bring them suggestions of what we think, or we'll work with a small committee from the board and we'll bring them suggestions, but ultimately it's up to the board to make these final decisions. And then DFR has to approve it, and then the statewide bargaining, takes what we've done and puts their stamp on it. Yeah, well, and their benefit design. Yeah.
And even before our board makes a decision, before we make a recommendation, sometimes it's options, multiple options for the board to consider. Our rate setting goes through a pretty rigorous actuarial analysis, as you would expect. And then it goes through another actuarial through DFR.
okay,
And then DFR, Bobby Joseph gets the final say, and it's usually in January or so.
Okay, so you develop plans and costs. And that goes to the bargaining group. And they,
Once it's been approved, it goes to
Once
the
it's-
bargaining group, yeah.
yeah, it gets approved. Then that is the group, and we've had a couple witnesses that said, well, we should allow. It's one or the other, and some groups have said they would like to be able to take, this from this plan and that from that plan. Create a third plan, but that's not allowed.
Right, the negotiators do not negotiate over benefits. How much hospitalization they have, primary care visits, ambulance services, et cetera. What they negotiate over is the cost sharing arrangements. And then there's some eligibility issues that they negotiate over as well. But they have the VI plans with the cost you see, then they negotiate over the cost sharing arrangements, along with a few other things.
Okay,
There are unions and employers, or employers and employees who actually negotiate at the bargaining table over the actual medical benefit. How many visits are you going to get
Yeah.
for this service or that service?
Yeah.
That's not what happens here.
okay, and the other suggestion that's been made is that we could consider freezing the actuarial value of the plans. What would happen if we did that?
So just a quick view what
Yeah.
actuarial value is, when you look at the qualified health plans on the exchange, they're called the platinum plan, the gold
Yeah.
plan, silver, and those all have an actuarial value.
Yeah.
And the value represents, so if it's a platinum plan, on average, the average person in the platinum plan will have 90% of their claim costs covered. So
Right.
that's how we kind of get to that point. Our plans that we design are at, well, I'll speak to the gold CDHP, which is where 85% of our membership is. Our full CDHP, the actuarial value is 87.4. So it's just below the platinum level, because the platinum can really go from 88 to 92. There's more
Yeah.
wiggle room there. And then when you add what the statewide bargaining has added to it, as far as helping with the coverage, helping with costs, it brings the actual actuarial value to 97.4 and 98.4, depending if you're a licensed or non-licensed group. So as far as like,
Pretty good.
huh?
I said that is a pretty good health insurance, whatever. You're at 97, 98.
Mhm.
Silver plan, I've been told, is cheaper, but has more value than the silver, because we have silver loaded. Has anyone ever looked at the silver plan?
Yeah, so we have a silver plan. The problem is it does increase the out-of-pocket exposure to the member exponentially. So it does increase the amount the member would have to pay. So it's when you add in the exposure and the premium, it actually doesn't really create a better benefit than what they have on the gold. So and I think what you might be referring to is kind of how the QHPs work with
State exchange.
yeah, the exchange with the
Yeah,
like the not funding, but like subsidies, and they can, kind of adjust the deductibles. So
yes.
yeah, I mean, there's ways to make the plans less expensive by increasing the out-of-pocket exposure for the members. Yeah.
Okay.
And then even if we switch to a silver plan, we would then give it to the statewide bargaining group, who would then decide how much that would be paid out of pocket by the member versus helped by the employer.
The statewide bargaining group is the school employees and school administration.
No, it's the, go ahead.
Sure, so, it's representatives from Vermont NAA and AFSCME, it's the union side. And it is, representatives from Vermont School Boards Association, VSB, and one side of the table.
Yeah,
union
that's,
side.
it's, yeah, the administration.
They refer to it as the commission.
They're commissioners, but they're commissioners.
Okay. But if we froze the actual work, because it's been suggested by one of the national or statewide organizations, actually, we've heard it a couple of times. If we froze the actuarial value, or if your actuarial value is 97%, I'm trying to figure out if you froze it. I can't imagine going to 100% right now.
That's what I was gonna say. It seems like freezing it, you would be freezing it high.
Yeah.
So I don't know, I don't understand
If less
that.
cost, yeah, I mean,
I
the
don't-
costs go up. No, if your actuarial value stays the same, you're paying 94, 97%.
Interestingly enough, the actuarial value goes up each year because the plan stays the same, but the costs go up. So, VHI is picking up more costs each year as these amounts go up because the cap for the member and the cap for the employer stays the same. But VHI is going up as these high costs are going up. That makes sense. So the actuarial value actually increases slightly each year.
Oh,
And actuarial value is an interesting conversation, and it's often a conversation had among actuaries, as you can imagine. And we are.
actuary, I know is above my pay grade.
Well, it's about mine too, but what's important to understand, and part of the reason why we share so many numbers with you today, so there's no correlation between actuarial value and book value. What you can afford to pay, whether you can pay it with charge, depends on your income. So I'll give you an example, and this is relatively recent, it's happened late last year. They tell you to stand 6 feet back within pharmacies, so you can protect people's privacy or give you your prescriptions. And I watched the gentleman at the counter beg for his medication. He was asked for $400. Didn't happen. He walked out without his medication. I went up after him. Got my medication. Difference between the two of us that I could afford.
Right.
He could actually have been in a high actuarial plan and not afford it. I could have been in a low actuarial and been able to afford it because of the income difference. It's always important to understand this is that whatever sort of intellectual or mathematical exercises we go through in actuarial value, there's no correlation between that and price. And importantly too, the work that's been done here in 2025 is beginning to address the systemic cause of the problem. That's why 120% average sales price on hospital administered medications can yield us nearly $15 million in savings without having to create any affordability pressure.
Once it doesn't get shifted onto the hospital.
Well, there's also the question of whether hospitals can operate more efficiently,
Yeah.
and that's
Well, some of us spent some time this morning
I
here.
imagine.
We are starting, we think, they got a message. We are beyond affordability. Both in hospital and pharmaceutical costs. Many years ago, this committee spent several years trying to do something about pharmaceutical costs. They are bigger and stronger and richer than we are, and may have had minimal effect, but that's about what it is.
Thank you. To your point about, affordability being income related, are your benefits structured so that the higher income employees in the pool pay more for their premiums. So
There's
that-
different cost sharing arrangements for licensed and non-licensed. So the cost sharing arrangements are not indexed to income,
Okay,
just a work classification.
okay.
For
That might be
licensed.
something to look at in that.
We can actually talk about that.
There are plans that are doing that right now that,
Yes.
yeah.
I should piggyback on that.
Yes.
So it still boggles my mind that my copay is $10 and my boss, who makes 4 times as much as me at UVM down here, it's also $10. So I just would love the income sensitization.
Yeah, that's what I.
Oh, I-
Yeah, that.
thing.
It's like your Mark Cuban story. I got to meet Mark Cuban for 15 minutes. That's my 15 minutes of fame, right? I got to meet him for 15 minutes in New York City last fall. I was asked to speak by a union about healthcare reform. I was asked to speak about what this legislature had done in 2025 because it's not being done anywhere else. So I was like, okay, I'll come and talk about these reforms and their impact on my pool and on Vermonters generally. And Mark Cuban was the keynote. And my union colleague said, so I can meet Mark Cuban. I said, yeah, why not? I did. We spoke for about 15 minutes. And I asked him about Cost Plus, his RX program. But he's also moving now into hospital contracting, direct hospital contracting. He wants to go into hospitals and he wants to teach other employers, big employers in particular, how to do this and negotiate directly with hospitals. Something I mentioned earlier. He said, I'm going to pay him a fair price. Reference it to Medicare. And I'm going to say to them, I'm going to pay you a fair price for these services. And you're going to see my employees and you're not going to charge them a deductible. He said to me, and I didn't expect the conversation to go. He said, what are you doing about deductibles? These are killing people. So I think there's a growing awareness that these high out-of-pocket costs, they clearly have not brought down costs. And they create the kind of affordability.
The idea is that if you didn't have a copay, people would have 3 colonoscopies a year.
Well, I hope not.
Maybe it's because I have one.
That sounds awfully good.
Yeah, I mean, if there are some people that might. I think they probably have a medical or psychological condition, but going to the doctor is not generally an overly pleasant process. It's inconvenient if you're a working person. Transportation in and out on all the issues we hear about. But that was the original argument for copays. It really doesn't cut down the cost. It's supposed to make sure you have some skin in the game, so you think twice before you go. But for some people, even a $10 copay is a detriment. And I think we know.
You know, to the point about where you get care and lower cost options and looking at some of the material here on page 7, Bobby Joe and I, or I should say VHI, was one of the early endorsers of licensing the Green Mountain Surgical Center as an independent standalone. So this was back in 2015, 2014. Bobby Joe's predecessor, Boris Soros, was in the working at VHI. We went to testify and supported this. We provided written information also endorsing the center. You may recall there was a lot of resistance from the status quo against that independent center. Fortunately, it was established. It is a very high quality center and it has lower costs. Blue Cross has recently rolled out an affordability campaign. We have endorsed that as well. We've said to our members, here's some low cost options for you to consider with surgeries and also imaging. It's mostly in Chittenden County at the moment. But again, for us, that's where a large percentage of our members live. If they get care at those centers, they're going to lower costs as well. We continue to put a premium on education and on supporting, standalone institutions like this that can deliver high quality care at a lower cost. And there's no question that they can do it. And coming back to the Act 167 report, let's get as much care as we can out of the hospitals. So there is competition around the margins in Chittenden. We try to support that as best we can. Coming back to a point solution we haven't talked about yet, is Hinge Health. You see this bottom of page 7. MSK, musculoskeletal conditions, are a big cost driver. Chronic pain is a big deal. And a lot of people end up getting medical care and RX. prescriptions because of that pain. And so we're in the second year of a partnership with Hinge Health. This is virtual PT. It has been enormously popular with our members. We've engaged about a little over 1,200 members so far in just the first year. 52% of them are reporting a positive outcome in pain reduction, and 82% reach what providers call a medically significant clinical benchmark. And that could be, for example, a greater than 34% reduction in pain. And then this next stat for us is really helpful to know. 23% of people who are doing this program say they are less likely now to pursue surgery. Here's cost savings. High quality care done in your home through a point solution, an independent vendor with VHI that is now more likely to mean you need fewer medications, fewer visits to a specialist, and fewer surgeries. All of that is cost savings for us as well. And that's part of our thinking when we look at new benefit design. Can we advance care options like this in other categories of need and lower our costs while also making sure our members get the best care? And by the way, there's no out-of-pocket cost for members for the Hinge Health. They won't take a client that has a deductible or co-payment. They say because it's an affordability barrier. You want folks to get this care, and we'll make sure you get a return on investment if these folks follow our therapists. And so far, the results are really promising.
I'll also add that it's less people leaving work. You know,
Yes.
you have to go to physical therapy, you have to leave work, go to the PT, go back. It's kind of time intensive, especially if you live in one of the more rural areas.
Yeah.
So allows people to do it at home before work, after work, at night, whenever they want to do it. Just, it's an app on your phone. So
I have to say, I was incredibly cynical and doubtful about this virtual PT. I thought, how can this possibly work? And then I met two PT folks at the gym one day who do virtual PT, two young people. And they gave me a tutorial. I thought, all right, maybe we should look into this a little bit
PT,
more.
you go, they put you through a few exercises, and then my husband comes home with a sheet of paper with pictures on it and maybe some stretchy things.
yes, yeah. This actually has like sensors on it that can make sure you're doing it correctly. So it's not just, hey, do this.
Wow,
It's,
that's even more advanced.
straighten your back. You need
Yeah.
to, whatever it is. So.
And finally, getting to page 8, thank you for your patience. By the way.
That's okay. This has been helpful.
Recently, someone reached out to me, again, Bobby Joe and I are always receiving inquiries from different vendors. Most of them promising the world and delivering far less. But in this case, this particular vendor really impressed me. They're offering another point solution, a specialty care program to reduce surgical cancer and infusion costs. As you can imagine, these are pretty big cost drivers. And I was really impressed with the presentation. Again, I tend to be pretty suspicious of this stuff. Shared some of the stuff with Bobby Joe and said, let's set up a meeting soon and talk with them. So that's in the works. And yesterday I went through a webinar that was sponsored by the North Carolina State Health Clinic. And they have recently, or the last couple of years, contracted with this vendor. And they were very optimistic and very positive about what they were seeing in the results, both in terms of medical outcomes and cost reductions. And now a shout out to our wellness program. And to your question earlier, Senator, about results. In addition to this being, what do you think it is, our most popular program of everything we do?
Oh my gosh.
Yeah.
I love it. For sure.
It's been around for a long time. It's gone through many iterations. What our data shows, and this is data that we work with Blue Cross to generate, is that those folks who engage with our PAC wellness program, again, as Bobby just said earlier, compared to folks who do not, they had lower per member per month rate of spending. We looked at this from a 2018 to 2023 period of time. They engage more with their primary care providers. They're more likely to have a preventative visit compared to non-participants. And recent Blue Cross data of our pool showed us that someone that's getting a preventive care visit every 18 months generates less in spending. They have lower frequency of ER visits, lower prevalence of diabetes, lower prevalence of hypertension, lower prevalence of medical health. So our colleagues in the wellness program are doing fabulous work. People are responding to it. Again, very popular. It's locally based. Sometimes it's part of the service programs, as well as folks getting information they can take home. There's all kinds of challenges that they can undertake in terms of lifestyle changes, exercise. It's another testament to the power of education.
That's good.
Yeah,
Is this program incentivized for members to participate or?
There is an incentive portion, each event or, each district can do like little events and things and they can gain points. And if they hit a 200 points in a calendar or in a fiscal year, there is a gift card that they will get, $100 gift card. So
The individual will
yes,
get it?
yeah, the
Okay.
employee. And it is offered not only to VHI members, but all employees that work in the building. So it's not just our covered folks, it's everyone. So
and Bobby Joe mentioned earlier, retirees have access to.
What about family members?
not family, just the employees, yeah.
I wonder if it would help to have. If it's saving money, like, and you're paying for
Sure.
a spouse. Maybe.
Yeah, and I think the reason that they do it just at the employee level is they do so many things at the schools.
Yeah,
They do, they might have lunch and learns and things like that right at the school. So it might be harder for a spouse to get there or a family member, but that's good fun.
yeah.
It's also, I think, popular in part because it is often collective effort, collective projects, people doing this together, learning together, exercising together, going for walks together. And so the collective communal nature.
Yeah, I mean, it does seem like you're missing half the population if you're only doing the employee. I mean, it also could be kids too. Somehow. They're in the schools, right?
Yeah.
They are, they're a captive audience.
Yeah.
So one last shout out, and again, we've touched on this before, but it's really important to emphasize the reference-based pricing reforms are landmark. I think you will recall this in particular when appropriation was approved, so we could do a reference-based pricing analysis for VHI's hospital claims and VSEA's hospital claims, or the state of Vermont's hospital claims. That appropriation allowed this analysis to go forward. It was done under the auspices of the Green Mountain Care Board with an outside vendor. All of the hospital claims were repriced to specific benchmarks relative to Medicare over a period from 2018 to 2023. The first 3 quarters of 2023, we couldn't get the data for the last quarter. But again, roughly 2018 to 2020. Multiple benchmarks, but the one that's probably most important since it's one that's being done nationally in Oregon. Washington just signed on to this for their public sector, 700,000 public sector employees, 300,000 in Oregon. If we had reimbursed Medicare, we had reimbursed our hospitals in Vermont, VI alone, at double what Medicare pays, 200%. Between 2018 and 2023, we would have seen savings of $230 million. That's where the rubber hits the road. That's where we have real promise in the future. So thank you for Act 68. And we're looking forward to the next iteration of the Green Mountain
It's
Care.
going through, the problem is that the majority of our hospitals are small, rural, and their financial sheets are in various shades of pink or red. If we cut their rates before other reforms can go into place, your members might find they have to travel to Chittenden County for hospital care. And so we're phasing it in. There's a lot of stuff going on. And we're trying, I mean, Brattleboro was our most recent. We did have Springfield go into bankruptcy. We want to make sure that the hospital care is there when it's needed, but it also needs to be affordable. So
Absolutely. And
we're trying to move it.
there were 2 things I learned from that. I learned a lot of things from that study. We learned a lot from this study. And 2 of the things that surprised me. And I've been doing this now for almost 25 years. Our reimbursements for our hospitals relative to Medicare between 2018 and 2023, just VHIs, went from 276% Medicare to 326%. 50-point jump in it. That is reflected in the premium you're seeing here, that 55% of hospital spend for our claims. The other thing I learned is that roughly 88% of our spend was with our 6 largest hospitals. Most of our spend is again highly concentrated at UVMFC and the network, but also with the 5 other PPS hospitals. UVMFC is by far the leader.
UVMC is one of the most it's one of the highest priced hospitals in the country. And they control a large number of medical practices and hospitals. So,
And I want to be clear.
they are making progress,
Yes.
but it's,
We want RVP implemented in a rational, fair, effective way. We want all of our hospitals to be financially sustainable, deliver high quality care. There's a regional transformation project underway now with AHS that's
yeah,
probably going to change the landscape. And the Act 167 report was again another landmark event for us that we're going to fundamentally change how you deliver care if you want your hospitals to survive. We have no interest in seeing any of our hospitals in dire financial straits. But we also have a deep interest, as you can understand, in making sure care is affordable.
I think we all
We do.
do that. I think that is one of the major drivers of the affordability crisis that we're in. That's national, but Vermont has the highest cost in the country. And we are not one of the richest states in the country, so it's definitely hitting home.
And we've been encouraged by what Dr. Lexlick has said recently at UVMMC about trying to move to Medicare benchmarks or Medicare break even over the next 5 years. There's clearly a recognition that we have to do something.
Yeah, there is.
And we're beneficiaries.
That could be.
That's my last comment on a Friday afternoon. Thank you very much. You're a wealth of knowledge and it's so helpful to hear from you. But I would say Senator Hardy, Senator Cummings, and I've been working really hard again to bring down healthcare costs and doing whatever we can to
As a health and welfare.
I know. Health and welfare light. And so, I'm also on the school board, so I know that losing the ability to negotiate healthcare has been not great, I would say overall. So I want to sort of echo what my colleague said. It would just be nice to see some real targeted efforts in terms of, deductibles, related salaries or whatnot. I'm not suggesting any particular strategy, but it would just be great to see that there's more
Income sensitive.
on the
Yeah.
back end happening as well, because we are, I don't want to speak out of turn, but we're in a situation now where we could potentially be really destabilizing our whole system with new maps and new districts and a new funding formula. And, we all need to be doing everything we can to break down those costs. So thank you.
Thank you.
And I
Appreciate the time to very much.
And
appreciate
when
it.
is the next time? I'm sorry,
No, go ahead.
Chair. When is the next time you all are in negotiations?
The parties, I believe, again, we have nothing to do with negotiation.
Yeah,
But
no,
the
I-
next time, I believe that's tabled in April of next year.
Okay.
And it goes into effect, the next benefits cycle will go into effect January 29. So right now the benefits are bargained through 28.
Okay,
And we're trying to link up our new plans with the next time the bargaining goes. So that way they have our new plans in hand when they go to bargain, as opposed to looking at our current plans.
right, and are you two responsible for doing some of the analysis, like if the income sensitivity analysis, or would that be
I
the,
think income
Marketing.
sensitivity would be outside of our purview, but
yeah,
in past bargaining cycles, folks have asked us for claims data, that kind of thing. That kind of nuts and bolts stuff we can provide. The
uh-huh,
question of how income sensitivity would play out in a negotiated settlement, that would be outside of the.
Okay.
So thank you. I apologize. I was late today because the Joint Fiscal Committee was approving the rural health transformation grant from the federal government.
Wow.
It's a very long and complex.
Yes, it's a lot of money,
But it is,
could be very impactful.
but it
Fortunately,
is,
you decided to give all the money to Franklin County. That's what I heard.
let's talk.
Addison.
Actually, it's going to be, it's being negotiated and renegotiated almost on a line by line basis. it is called a cooperative agreement. It is not a grant. And the cooperation is 2 full-time people and a lot of telephone and emails, I gather. It is highly supervised. So it is changing on a daily basis, but it's in, and hopefully it will help to the foundation, I think, for especially, well, it has to be in rural areas. So rural, really a foundation for basic primary care and then access to specialty.
Yeah.
So I think that one is in process. Okay.
Thank you again.
Thank you.
Appreciate the time.
Thank you, Jim. It is hard work and it's always good to know what is going on.
We ask ourselves that every.
Yes, it is. Okay. So committee, that is it for today.
Oh, really?
Great.
Wasn't there something in it on it?
I've given this.
Sorry.
Sorry.
Wait. Our other testimony canceled. Yes.
You just didn't want to.
Yeah, no, we had other testimony and they canceled. So that was it.
Been incredibly easy on us this week.
I know, well, no, you were here till 5:30.
Oh, we got a break.